It's very important to know how to manage and when to use JAK inhibitors and which ones. Now with the more options, everybody feels happier that if patient doesn't respond to one JAK inhibitor, to switch them to the second. But there I would like to get a little bit more of a careful thinking. In a second line setting, we have not seen such an impressive and durable responses. So just because we have available JAK inhibitors, I would emphasize to utilize the strength of the frontline one, and if there is an add-on strategy, please try to do that, so we don't end up switching more therapies very early and then making patients refractory to agents they have not even utilized to the full extent. I think that's a really important point. We have seen this in the CML when it was developing across different TKIs, but that's a little bit different story where really the drugs go after the disease clone. In myelofibrosis, that's not the story. The mechanisms of resistance, of response and non-response are different. So that's something I would caution against and kind of like more consult the community, the experts. Hey, do I switch? When is the best time to switch? Is the patient failing? Is the patient just not dosed properly? What can I do to improve on that? That's a very important thing, I would say. I think a quality of life, focusing on where the drug is working, where it's failing, is very important. And then of course, for any more complicated patients or patients that are very young, atypical presentations, to really try to see whether there is any clinical trial open or any larger community or expertise, because unfortunately at this time we cannot offer a cure to these patients, and if there is any patient that is reasonably young, we have to think about the stem cell transplantation referral go very early on. So to me it would be an ideal world where everybody who manages the patient has quick access to expertise, to look at the clinical trial, somebody on call and ask them, hey, this is it, I'm seeing a few patients in the year, is this the best management, can I reach out if I have any issues, rather than putting a lot of the stressor on patients to travel miles and kilometers to even different countries to seek expert opinions. So there I would like to see some kind of of that. I think that's a very important message to the community, doctors, and then even there is more JAK inhibitors, just really think before you switch and ask, is this the best step to do, rather how can I improve on the first one, and even before, is this the best to start with, because now we have treatment agnostic options, so we can choose among those four even up front. So there as well, considering patients' characteristics, comorbidities, tolerance are very important for choosing the best treatment, and then keeping the first inhibitor as long as possible. That's pretty much my message.